Hello. Yeah, we can start now our theme. Neha madam, Chitra madam. Thank you. Dr. Jay sir. Hi. Okay, let's start with our today's program. Today's is the 12th program on Maha IAP Sub Speciality Clinic. And we have with us Dr. Abhanagral today. Before going for introduction with Abhanagral madam, we'll just have some highlights from our previous 11 programs on Maha IAP Sub Speciality. So, along with Dr. Jayakumar Bhandarkar sir. Sir, are you there?
Yes. Are you?
Yes. Yeah. So, will you please start and telling us what and why we are doing this program?
Okay.
Yes.
Thank you, Samir. And at the outset, I'm very thankful to our own MahaIP team, led by Dr. Hemant Gangulia, our secretary Amol, Vice President Vinayak, and all other office bearers. And I know today is the last episode of this year. I'm not talking about the next year. And I'm very glad we're able to pull all the sub specialties throughout the planning. जो दिमाग में था वैसे कि डोक्यात होता आपल्याला की sub specialty एक important with stalwart speaker we should cover. And to be very frank with you, we are blessed with a very good friend of mine, Dr. Samir Sadavarte, for this sub specialty chapter. And whatever episode occur throughout the years, I will give 99.99% credit to Samir for this. He is bringing just I am giving his name of the speaker, and he said, I will contact him, I will talk with them. So we have fantastic run throughout the year. And though I am seeing on the screen, but it is also a teamwork. And thanks to Neha, Vishal, Dr. Amol Secretary, Dr. Hemant, ही सेड की तुम्हाला जे करायचं तुम्ही आनंदाने करा, काही प्रॉब्लेम नाही, काही अडकाठी नाही त्याच्यामध्ये. And at the outset, I thank to Abha Nagaral madam for accepting so that I was planning somewhat different about hepatology only. And thanks to madam for coming to this last episode, very important organ. We're talking about the hepatology. And as a general pediatrician, we just cater some condition like a neonatal jaundice, maybe viral hepatitis, and rest we just refer to hepatologist for the further if there is something odd we see. So I think I hand over to Samir to start this. Take blessings from Dr. Hemant, Dr. Amol, and who the OBs are present here, and many people are even this login in a large number. Thank you very much.
Thank you, Dr. Jay. Sir has already mentioned about the Maha IAP. So Bhandarkar sir actually telling my credit, but actually I have to say that his vision is so nice that every last 3 months we just plans what to do in the next month. Like so far we have done for the ENT, ophthalm, we have kidneys, X-ray chest, and then we have anemia. All the programs were quite hit. So last session was remaining was the liver, and we have no other name in front of our eyes. That was only Abhanagral madam's. So we thought and asked madam just a few days before, and madam has said yes for this today's program. So thanks Abhanagral madam for having here today. Before I give handover to madam, I'll just have a quick CV for her. So I don't need to introduce her. She's such a wonderful lady and doctor. She has all the things related to liver. If you think of something, Budd-Chiari syndrome, let's see, we have liver failure, we have transplant liver. The final word actually comes is from the Dr. Abhanagral. So madam, from last 29 years, she is working continuously in the field of hepatology and the liver. Apart from the general medicine and general pediatrics, what she does. She has been awarded with the gastroenterology, DNB, and the fellowships done across the world. And particularly for her special interest is in hepatitis Budd-Chiari syndrome, Wilson's, Gaucher's, Porter hypertension, and with the liver transplant. Has received multiple awards across the globe, and also has received the scholarships from the London, from the USA, and has received the Mahila Gaurav Sanman Mumbai in 2008, and various prestigious fellowship programs, and has saved thousands of the pediatric kid patients with a liver and liver related injuries. So over to Dr. Avanagral madam for today's session to start with. So Dr. Avanagral madam, are you there? Please start.
Yes, yes, I'm there. Thank you, Samir, for this long and detailed introduction, and thanks, Dr. Jaikumar, Maha AP subcommittee for this sub-speciality meeting. I think it's a good idea to have these meetings. And do we have it like a questions will be put on the question box? How will it go?
Yes, you have questions that you just put it, and then people will answer in the chat box. And also to note that many people are actually seen on live on the YouTube also. Okay. So if they post on the Maha IAP on YouTube, they will able to see this one now and in the future also.
Okay. Okay, so I have to share my, where does it go? Settings. You have to give me that sharing option. 1 sec.
Yeah, ma'am, already been given.
I can't see it in the more.
Share screen option, ma'am.
मला share option दिसत नाहीये.
Asha madam, it's written that Avanagral co-host is there, so you can.
No, but it's not giving me an option of share.
Have you joined from the laptop or the mobile?
Laptop.
So below you see the green button, share screen, down.
No, I'm not. नाही मला ते बटनच दिसत नाहीये. Sharing.
Participant, chat, share screen, record.
Reactions and more. आणि more मध्ये there is no share.
More मध्ये नाही. खाली.
Settings मध्ये असणार का? Settings मध्ये पण नाहीये.
नाही, settings मध्ये नाही मॅम. एक तर more मध्ये किंवा in the front menu.
मॅडम तुम्ही YouTube ने केलेत का? तुम्हाला यांनी जायचं आहे. I send you the link actually. If you want,
she had joined from Zoom itself, sir.
Yeah, so in the Zoom, madam.
Ma'am, आता Zoom वरच आहेत आपल्या बरोबर.
Okay.
Yeah, but I'm not getting the share option.
Below you can see mute, stop video, security, participants, chat.
You can go start from the first, madam. Then I think probably. And open the first whatever you want to show. PPT, please open it first and then go on Zoom.
Yeah, 1 sec. I'll just. कारण की ते share नावाचं option नाही दिसत आहे मला. Can you see my screen?
We can see your photograph only, your videos only, not this one.
Ma'am, I think you have to rejoin again.
Yeah.
But should I rejoin from the Samir? You had sent a link. I have joined from that link.
Okay, I will send you again. If
yeah.
Wait for 1 second. I will send you.
She is there on this. There is no problem. But she should exit the full screen. Just she will be able to see the things.
Madam, you are already here, so you are already on the Zoom, correct? Or you can log in again. I send you the meeting ID also, and also asked you to join directly with the US02 web if you go back and check.
ना ते लक्षात येईल त्यांचं. तुझ्या लॅपटॉपचा स्क्रीनशॉट पाठव त्यांना. खाली ते स्क्रीनशॉट करून पाठवून यायचं. फोटो काढून पाठव ना.
हां.
लॅपटॉपचा फोटो काढ आणि ते पाठव त्यांना.
I'll send her email then otherwise.
नाही ईमेल नको पाठव, व्हॉट्सअप वरती पाठव ना फक्त इमेज.
नाही व्हॉट्सअप पाठवला ना, ऑलरेडी पाठवला. I sent her.
Ava ma'am, you have to leave the meeting and again rejoin.
Yeah, leave meeting and then again rejoin, madam. That is the best option.
Madam, in the meantime, you can send your presentation to the Samir. त्यांचा mail पाठव ना.
Hello, madam.
नहीं मैडम, आपका ये ईमेल आईडी भेजो समीर के पास. समीर को बोला मैडम को भेजने को, शेयर करने को बोला ईमेल पे. नया मैडम, आपका नंबर, आप उनका नंबर आपके पास में, तो आप उनको भेजिए आपका ईमेल और बोलिए प्रेजेंटेशन भेजिए.
I don't have, sir. Sorry, sir, I don't have the number.
नंबर
Sameer, sir, I have sent you my email ID. If she wants to share, I can share. But she has to mail me.
ये नंबर शेयर करना नया मैडम से. मैडम का नंबर शेयर करा. सभी देखो नंबर, नया देखो नंबर है, उनको व्हाट्सएप करो, बोला कि शेयर ऑन दिस ईमेल योर प्रेजेंटेशन.
आभा मॅम जॉईन झाल्यात परत आता सर.
नाही दिसत मला.
केलंय मी त्यांना होस्ट आता लगेच. फक्त व्हिडिओ आला तर आपण परत एकदा सपोर्ट देते.
हो ना. दिसत आहे. व्हिडिओ ऑन करा सांगा त्यांना. मैडम, कैन यू हियर अस?
मला वाटतं समीर सर बोलतायत सर.
बरेच जण जॉईन झाले तो.
हो ना. Hello. हाँ.
समीर हो गया? टॉक विथ मैडम.
सर मेगा मॅडमचे पण लिहू ना. मेगा
हा हो
मॅडम
त्यांचं नाही ऑनलाईन जे ते लिहून टाक. Good evening, friends. Just Madam has joined. Some technical issues there. We'll be starting within short time. It's the last episode of this year, Sub Speciality.
एक मिनिट. समीर
हा हा.
ते ना माझ्या मेल आयडी वरती पाठवायला सांग, कारण नेहाच्या मेल मध्ये काही ग्लिचेस आहे.
तुमचा HR गंगोली आहे ना सर?
gmail.com.
HRGANGOLIA@gmail.com. ठीक आहे, आय विल जस्ट सेंड.
मॅडम शेअर करतायत का?
Oh, madam, actually she is not able to see, so I send her email of sir Gangulia sir ka.
हाँ.
HRGANGOLIA@gmail.com.
मेल आया क्या आपको? आया क्या आपको? मैं देख रहा हूँ. समीर फॉरवर्ड करा सांग, आला नाही अजून माझ्याकडे.
I have sent her your email also, my email also, both actually now. Madam has sent to hrganguly@gmail.com. Hello.
आया बोलो. हेलो
सर तुमच्याला आलाय का गंगुले सर? तुमच्या जीमेल मध्ये आलाय का बघा बरं. गंगुले सर, गंगुले सर तुमच्या ईमेल मध्ये आलाय का?
हो, काल शेअर करतो मी.
Madam messages that she has sent to hrganguly@gmail.com.
I got the mail. It is opening. Just give me
Okay,
time.
okay sir. ठीक है. So dear friends, sorry for some delay from technical issues. We'll start in next 1-2 minutes now.
दिसतंय? दिसतंय का?
नाही सर, अजून दिसत नाहीये.
नाही सर, शेअरिंग नाही दिसत आहे.
अजून नाही दिसत आहे. हा, हेमंत गंगोले has started screen sharing. सर आता दिसतंय. At least started sharing.
Hello.
Hello, madam.
Yeah.
Ah,
Can you?
Yeah, you able
Yeah.
to see, madam, now?
Yeah. I can see now. Yeah. Thanks.
Okay, great.
Okay.
So start now. Yeah.
Okay. Yeah. So I think I'll just start right away.
Yeah.
I'll just start with some basic. Now I can't move the slides, right?
No, you will not able to move now. You have to say yes, something like that.
Sorry. I'll just keep saying next.
Yeah.
Sorry about this, but somehow I'm not able to share at all. Okay. So can I have the next slide, please? So I'll just start with the basic liver profile that these are the tests which we normally do. So you will be familiar with most of these tests, but the important thing I want to point out here is that when we talk of liver profile, the term liver profile is preferred to LFT now because we are not actually quantifying the function of the liver. So the term liver profile is a preferred term. GGT and prothrombin time do not come as part of a liver profile often. Some labs give it, but most labs don't give it as part of, and they are very important tests of liver function. So these need to be included as liver profile, and LDH is often given as part of liver profile, but we hardly use LDH in our regular day-to-day clinical practice. So probably has little role in analyzing liver function tests. Next slide, please. Next slide. Yeah. So there are some differences which one should be familiar with when we talk about liver profile in children. One is that the alkaline phosphatase is higher in infancy and pubertal age. We know about pubertal age coming from growing bones, but it's also higher in infancy. The ALT and AST, ALT is SGPT and AST, the median level for girls is lower than in boys, and it's generally lower in children compared to adults. Now, GGT, gamma glutamyl transferase, is seen at a higher level in neonates, and they'll reach adult levels by 6 to 7 months of age. So it's very important to be able to interpret the GGT right. I'll show you some nomograms. You can just take pictures of those to keep an idea of what a GGT in a neonate or in the early infancy can be. Neonates tend to have lower albumin, and alpha fetoprotein can be very high at birth. It comes to about that of adult values or normalizes by 7 to 8 months of age. Next slide, please. Now, how do you interpret liver profile? So when we talk of liver profile, it's either an acute presentation, so it is an acute infective illness or any acute illness, or it could be a silent chronic illness which has presented acutely. So just because it presents acutely does not mean that there is no chronicity. It could be chronic illness which has presented for the first time acutely, and we'll talk about some of these. Or it could be a chronic presentation. That means you've identified a child with abnormal liver tests, you're monitoring them, the liver and spleen are slightly enlarged, and then you find that the LFTs are going on to be abnormal for some time. So, and if anything more than 6 months, you call it chronic. And often when you incidentally pick up liver disease, for example, you incidentally pick up a child who's going for surgery to be hepatitis B surface antigen positive. Most of these incidental pickups are chronic disease, which are silent and therefore not manifest, but they are chronic. So that's another way in which we pick up chronic diseases. Next slide, please. So I was told by Samir that we need to talk about 10 cases. So I've got these 10 cases and trying to cover most of the liver profile spectrum. So this is an 8-year-old boy, comes with jaundice for 5 days. It's preceded by typical prodromal symptoms, nausea, anorexia, vomiting, little right upper quadrant pain, and fever. He has history of dental work done about 3 months back. AST, ALT are raised. ALT, which is SGPT, more than AST. Bilirubin is quite high. And this is his rest of his liver profile. GGT mildly raised, INR normal, upper limit of normal, albumin and globulin. Next. So if I were to ask, okay, what is the diagnosis? Now you have SGPT or ALT more than SGOT. Bilirubin is quite high. He has come with symptoms which are of, and this is something which you are very familiar with, so of prodrome, which is nausea, anorexia, vomiting. And his synthetic function of the liver, INR, albumin, which I'll talk about, are normal. So the first thing which comes to your mind is this acute viral hepatitis. So he turns out to be HBsAg positive. To know whether it's acute or not, you do an IgM anticore. And this by itself does not mean it's acute. Even if it's an acute presentation of chronic, like a flare, your IgM will be positive and his DNA is high. Now he gives history of dental work. When this hepatitis B comes back positive, we want to take high risk history, and there is history of dental work 5 months ago. We know that the incubation period is anywhere from 6 weeks to 6 months. Next, please. His other viral markers are negative. Next. And his ultrasound shows that liver is hypoechoic. Just can we go back? The gallbladder wall edema is there. So there's a thickened gallbladder wall and there are some small periportal nodes. Now, the reason I wanted to show this ultrasound is that these are the typical features of acute hepatitis. The liver could be hypoechoic. The gallbladder wall edema will be there. And this is often called acalculous cholecystitis by sonologists, which is not a correct term. This is a part of hepatitis, so one need not get alarmed by this. And small periportal nodes is very much again common with acute hepatitis. So just to tell you that this is a typical picture on ultrasound of a viral hepatitis. High enzymes, prodrome, all this points towards viral hepatitis as an etiology. So this is simple. Next slide, please. So coming to the next case is a 10-year-old girl. Again, she has some prodromal symptoms, but she gives history of these over 6 to 7 months. So this straight away changes your thinking that this is not acute. This is going on for more than 6 months. Her platelet.
Excuse me, madam.
Yeah.
Samir and Dr. Jay, do you want to ask something after each case, or you want to take up at the end? Dr. Jay and Dr. Samir.
I think we can take up at the end. I can keep a watch on the chat. If somebody wants to ask about a case immediately, then they can put it up on the chat. I think that will be easier. Yes. Yeah.
Okay.
Yeah. So I'll keep a watch on the chat. So, so as I was saying, coming back to this case, that this child has symptoms going on for 6 to 7 months. There are joint pains as well. Bilirubin is 3, ALT, AST raised, alphos mildly raised, GGT okay, INR borderline, albumin borderline low, and globulin is high. I think I've got the wrong slides, but anyway, it's okay. So next, please. So one thinks of viral hepatitis, but the reason why all viral markers are negative is, let's just see this. This is important history. It's going on for 6 to 7 months. Okay, the other subtle features, what are the subtle features here suggesting chronicity? The albumin is a little low, okay, and the globulins I have marked are high. So before we go on to the next slide, any thoughts on this? What this could be?
Hepatitis A is positive IgM.
Is a chronic active hepatitis or maybe?
Yeah, so most people are saying autoimmune. Yeah, so we used to use the term chronic active hepatitis, but we don't do that anymore. We call it chronic hepatitis, and then we add the etiology. So the terms chronic persistent, but it is active. Of course, you're right, it is active. Just that this term is not used anymore. So yeah, most people have got it right. Can I go to the next? Yeah, so somebody got these tests done, which there's no fever, so I wouldn't really think of these three, but it was done and they're negative. Next. And this is what comes back. The ANA is significantly positive. Now, this is the ASMA anti-LKM1. Now, LKM1, liver kidney microsomal 1 antibody, is seen only in children. We do it only in children. And those who are LKM1 antibody positive, they have the type 2 type of autoimmune hepatitis. These are the ones who do not respond easily to steroids. And these are also the ones which relapse after they have responded. So they have a worse prognosis, the anti-LKM ones. But fortunately, even in children, the commonest one is type 1, where you have ANA or ASMA positive. And the other test which we do is IgG, total IgG, not any specific IgG. Total IgG is normal up to 1600. This is 2800. Now, what was the clue? The clue here was the globulins. So if you have a child with a high globulin, okay, high enzymes, AST, ALT, this should be AST actually. This one is AST. And an albumin which is borderline low, platelets which are on the lower side of normal, WBC is on the lower side of normal, telling us that there is some chronicity, probably hypersplenism going on. Then think about a chronic liver disease which has a hepatitic presentation. So autoimmune, yes, you've got it bang on. It is autoimmune. Next slide, please. I'll not really go through the detailed discussion on management. The treatment is mainly steroid based for these patients and they do fairly well, especially this type 1. So now talking about, since they were high AST, ALT, they are now referred to as transaminases. These are an indicator of microinflammation. So in an acute setting, if you have high levels more than 400, it could be a viral, but it's not only viral, which gives you levels in thousands. It could be a drug hepatitis, which can give you similarly high levels. And even in autoimmune, you can get very high levels. So remember that it could be any of these three. It could be an ischemic hepatitis after an attack of hypotension for whatever reason. The values suddenly go up. And here I would say LDH has a role where LDH also goes up. So if you have a high LDH and sudden rise in enzymes without any prodrome in thousands, which come down also very rapidly if the hypotension is corrected, there's no need to get viral markers done. This is ischemic hepatitis. Even when a gallstone passes into the CBD and from the CBD into the duodenum, it can cause rise in enzymes. But again, take the history. There's no prodrome. It's an acute onset abdominal pain which lasts for a few hours and then suddenly goes away. So this is not the history of a viral hepatitis or an ischemic hepatitis. Think about gallstones. If you have stones in the biliary tree or stones in the gallbladder, this could be high enzymes. You can get enzymes in 4, 5, 6, 700s also. This is due to a passage of a stone. Or it could be just modest levels which are rising, like less than 400. So it depends even in a viral hepatitis when you're picking it up. So if you have the child coming to you in week 3 of the illness, you will not get enzymes in thousands. You'll get enzymes maybe in hundreds. So this is a child where you have probably missed the peak of the enzymes. And you're seeing the child in the 3rd week when the bilirubin is probably going down or even going up. So when the bilirubin goes up, the enzymes are actually coming down. So it all depends on when you see the child and whether the enzymes are high or not. Sometimes you see the child in the 4th or the 5th week. We don't have any previous reports. The enzymes are normal, but the bilirubin is 25. So it could still be viral hepatitis because we've missed the peak of these enzymes. So that's what I want to highlight. And in a chronic illness, you need to document for you to say it is chronic hepatitis that the enzymes have been abnormal for more than 6 months. Now, the important point here is that just because levels are very high does not necessarily mean that the patient has severe disease. You could have high levels with a relatively mild disease. So levels may not correlate with disease severity. Next slide. Please, if there are any questions, keep putting them up on the chat box. Next slide, please. Now, okay. So when we talk of ALT more than AST, SGPT more than SGOT, typically for viral hepatitis, it is any of these infections, what we call hepatotropic viruses. Hepatotropic viruses are which mainly multiply in the liver. But if AST is more than ALT, then you think of non-hepatotropic viruses. And the commonest one, anybody? Non-hepatotropic viruses causing AST more than ALT. We can chat it here, put it in the chat box.
Dengue viral, ma'am.
CMV not the commonest.
Dengue.
CMV of course is one of the reasons, but dengue is what we see as the commonest.
Dengue.
Where AST more than ALT, and we have seen AST sometimes in 10,000s also. And we know that higher the levels of AST, ALTs, more severe is going to be the attack of dengue. Yeah, next slide, please. So these are all the non-hepatotropic viruses, which means they are multi-system. They are not only affecting the liver, and this has implications in management also. Sometimes they come with a liver failure, acute liver failure, and then we have to think whether they need a transplant or whether a transplant would be contraindicated because this is a multi-system problem. So it could be any of these, but dengue is clearly what we see. Recently, there was an outbreak in England with an unknown virus which caused a hepatitic illness in children. And most of these children had adenovirus. That's what they identified. Next slide, please. Now, AST more than ALT in a chronic setting. I spoke about acute setting. So once you have, say, a patient with hepatitis B, chronic hepatitis B, if you find AST is more than ALT, you know that there is significant fibrosis happening. So AST becoming more than ALT means there is more fibrosis happening, more chronic disease. Next slide, please. Next. Yeah. So there are other causes. Ethanol hepatitis, typically you may see it in teenage children. We do know that a lot of teenagers, even in India, are taking. So here, AST will be more than ALT, but usually in ethanol hepatitis, they don't go above 400. So if it's anything more than 400, rule out ethanol. But don't forget that it could be a muscle and cardiac involvement. And we have really burnt our fingers where we have a patient referred to us with high enzymes, nothing else, no other symptoms, just ALC, AST high, sometimes even ALT more than AST, but often AST more than ALT, where we have done a CPK. When after we have done everything, all possible etiological factors, then we've done a liver biopsy not showing much. And then we realize, is this really liver or is it something else? And then we do an echo, we don't find anything, done a CPK and a very high CPK. And then we look at the legs of the patient and we find that there is calf hypertrophy. So there have been at least 4 to 5 such patients I have picked up in the last couple of years where they have just been referred for, there's no weakness history, nothing. They've been just referred for high enzymes and it turns out to be Duchenne's. So if you do not get any cause, I would say even if you see a patient, I have now started looking at the calf muscles of all patients so as to not miss Duchenne's in patients who have just presented with high enzymes. And of course, with time they do progress, but they are referred to you probably early where only the liver tests are abnormal. Next slide. Now, what is a function of albumin? Yeah, we can have the next slide. It's basically a synthetic function of the liver, which has a half-life of 3 weeks. So low albumin implies a decreased production. We know that liver is the only organ which produces albumin, or there could be increased losses, like in kidney, nephrotic syndrome, or a protein losing enteropathy due to various causes. Now, how do you know that this is a nutritional cause? First of all, look at the family, look at the socioeconomic strata. Does it look like a family where the child is, malnourished? Are there other signs of malnutrition, or is it just an isolated albumin which is low? Typically, in nutritional low albumin, you'll have low globulin as well. And that is a giveaway. In a liver disease, the globulins will be high because globulins are made by are synthesized by rest of the reticuloendothelial system, whereas albumin is only by the liver. And in pregnancy during the 3rd trimester, because of dilution, you get low albumin. So a low albumin could be any of these. In a liver, liver cause, typically it is a chronic disease where it is going on for more than 3 weeks, which is the half-life of albumin. It may not be just more than 6 months. You'll see even in an acute viral hepatitis, which is going on for a longer time. Sometimes they go on in a cholestatic phase for 3 months, 4 months, the albumin starts dropping. So it is a synthetic function of the liver. Next slide, please. So coming to the next case, this is a 9-year-old weighing 30 kilos, presents with fever, anorexia, followed by jaundice for 15 days, and mother is giving on her own 2 hourly paracetamol. Now, the child on examination, on investigation, is found to have high enzymes, ALT, AST both high. Bilirubin is 19, ALP, GGT also moderately raised. Albumin 3.5, globulin 3.3, so unremarkable. The jaundice progresses over next 7 days, and the child has now become irritable, refusing to eat, and just keeps on sleeping unless woken up. At this stage, the child is diagnosed to have a liver failure and is referred to a hospital for a potential transplant. When we see the child, now see what has happened. His AST-ALT has come down, but the bilirubin has gone up, what I was telling you earlier. But INR is now 4.5. Outside the INR was not done. So that's the other important message. Do an INR, especially in a patient who comes with a high bilirubin, or where the bilirubin has been going up, or the child sleeping excessively, irritable. I think INR is a single most important test here. So we do an INR which is high. It is not correctable by vitamin K. So that is an important thing. The moment you see a high INR, give vitamin K. If it is not correctable, may I know anybody? Achha, there's somebody giving me the diagnosis of paracetamol poisoning. Okay, yeah, that's a possibility now. But I just want an answer to this question. If the now somebody has said FFP, I don't want the treatment yet. If the INR is high, 4.5, bilirubin is high, what is the first thing you would do to know whether the child is in liver failure or not before doing ammonia? Anybody? Any other treatment, simple treatment you'll give, which I'm sure you give all the time?
Vitamin K with is correctable or not? We can check
Yes,
it.
exactly. So you'll just give vitamin K. And even with 1 dose of vitamin K, it should get corrected. You give 3 days, but there's no point in giving for more than 3 days. So you give vitamin K, and if the INR normalizes, anyone, what does that mean? INR has normalized.
Maybe synthetic function of this liver is maintained. We can say recoverable. We can say prognosis may be more better.
Exactly. So the synthetic function is maintained. So basically, by is your prothrombin time or INR high, because prothrombin time depends on which factors, which clotting factors determine the prothrombin time?
257.
9. Yeah. So these are the factors which are, yes, 2, 7, 9, 10. You're right. So these are the factors which are vitamin K dependent, which are produced by the liver. So when there is cholestasis, the bile is not coming up into the duodenum, there is no vitamin K getting absorbed because it's a fat soluble vitamin which needs vitamin K for its absorption. So what do? You bypass that. You give vitamin K parenterally, which reaches the liver, and liver has vitamin K to produce these clotting factors, and your INR normalizes. But if in spite of vitamin K being given, your INR does not normalize, it means that your hepatocytes are sick. Any amount of vitamin K you give, it is not capable of producing or synthesizing these clotting factors, which means this is a child who is going into liver failure. So that is the importance of vitamin K and understanding the INR and the correction of INR with vitamin K or not correcting with vitamin K. So this child does not get any correction with vitamin K. It remains high. We do an ammonia which is very high. There's no any family history of liver disease. Now, if anybody here, what will you do next? So I've got various answers. Yes, you may try N-acetylcysteine. So this is a liver failure, and somebody has suggested that this is liver failure due to paracetamol. Okay, but the point is the patient has come with jaundice and then has been given paracetamol. So any clue? Has come with jaundice and fever and then been given paracetamol.
It may be added to the existing viral hepatitis, some infection, and it paracetamol may be added to that insult to the liver.
Exactly. So next slide. So we do viral markers and the Hep A comes positive. Autoimmune markers are negative. And when we calculate, this child was getting a combination of ibuprofen and paracetamol. And the mother did not realize that what she was giving as ibuprofen was not only ibuprofen. So that's another, ibuprofen also can be hepatotoxic, but ibuprofen plus paracetamol and paracetamol is what she was doing alternately. And this is the dose that the child got. Anybody knows what is the hepatotoxic dose, single dose of paracetamol in a child?
150 gram per kg stat.
Absolutely, on the dot. So this was definitely more, and on addition, over and above, the child was Hep A positive. In fact, even if the child would have got, say, 80 milligram, when there is an underlying liver disease, even that dose can become potentially hepatotoxic. So the moral of the story is that if you have a patient with a liver problem, then you have to give lower doses. But this child, of course, got toxic doses. So it was a dual insult. And that's one point I want to highlight. Not saying that do not give paracetamol. You can still give it, but take care that you're not giving combinations which have paracetamol, and give the right doses. Next slide.
So in hepatitis to control fever, paracetamol or ibuprofen is preferred?
Paracetamol. It is still paracetamol, but the right doses. This child inadvertently got more because he was getting paracetamol in that combination drug also. That's what happened. And then ibuprofen by itself also has some hepatotoxicity.
Madam, I have one question for this case.
Yes.
Few patients are whether are susceptible to genetic predisposition to the paracetamol poisoning itself.
I agree, but we don't do those tests, and we know that those tests are not are not going to come right away. You're right, but basically from our end, we don't go more than whatever 10 milligram per kg per dose, 4 hourly or whatever. So I would say that this is the paradox. The paradox is that given a child with liver, acute or chronic liver problem, paracetamol is still the safest drug to give. But take care that you're not giving combinations. Again, this whole thing about whether you're giving drops or syrups or suspensions, because the concentration is different in different preparations. So that's the other thing you need to take care of. And don't give combinations, and given the right dose, especially in a situation where there is a liver problem. So that's the only thing I wanted to highlight over here. I would still give paracetamol over the other very common drug used is mefenamic acid. Do not use mefenamic acid. Do not use ibuprofen. These are initially many people use nimesulide. In fact, it was banned because it caused acute liver failure. So do not use nimesulide. So basically, in short, don't use. Yeah, somebody's asked, is it safe to give mefenamic? No, it's not safe. So these are drugs which are commonly used in pediatric practice and should be avoided. Just use plain simple paracetamol in the right dose. That's the point I want to make here. Okay, so this child actually had acute liver failure. And when do you say that there's acute liver failure? When there's liver dysfunction within 8 weeks of onset of symptoms. When the coagulopathy is uncorrectable. So if you have an INR more than 2, then irrespective of whether there is encephalopathy or not, this child is in acute liver failure. That's the definition. It's different from what it is in adults. In adults, you need encephalopathy. If the INR is 1.5 and between 1.5 and 2, then you need encephalopathy. But INR more than 2, like in this child, it was 4.5. Even if the child was not irritable, I would take it as, it would be defined as acute liver failure. And of course, there should be no evidence of any underlying chronic liver disease. Next slide. So prothrombin time, we've discussed this. It's again a synthetic function marker, but how is it different from albumin? Basically, it measures clotting factors which have a much shorter half-life of few hours, whereas albumin has a short life of 3 weeks. So that is the difference. So your prothrombin time will rapidly become abnormal in a child who is very sick, whose liver is very sick. Does not happen with albumin, doesn't become abnormal so easily. So that's the importance of prothrombin time, and that's why I mentioned right in the beginning that it's a very important test of prognosis and of liver function, especially in the acute hepatitic setting. So in acute liver failure, you'll define it when it does not get corrected with vitamin K. Even if you have a child with, say, cirrhosis, and he has come to you with ascites, with all the other complications of cirrhosis, his INR is hovering around 2.3, not getting corrected. This is again a chronic liver disease where the synthetic function has got affected. Any cholestasis, so you have a child of biliary atresia coming with we have children of biliary atresia presenting for the first time with intracranial hematomas or hematomas anywhere else. You find INR of 6, you give 1 dose of vitamin K, it's back to 1. So that is a cholestatic liver disease causing high INR, which is very easily correctable by vitamin K. So understand this and do not give vitamin K for more than 3 days. If it's going to help, it will help for 3 days, within 3 days, otherwise it's not going to help. I will not give, somebody mentioned FFP. Now, again, we are not discussing treatment in detail, but unless the child is bleeding or you're doing an invasive procedure, we do not correct the INR. So you may have an INR of 6 and 7. We will not correct it unless these two situations are met, or unless we are thinking of a transplant, when we will start correcting the INR. Because the INR or prothrombin time is going to give you a very good idea of the prognosis of the patient. If the prothrombin time is increasing, INR is increasing, it tells you that the patient is unlikely to do well. So it's extremely important that we watch the INR in a sick child with hepatitis. Next slide, please. So this is the next case, 1.5-year-old, born of a 3rd-degree consanguineous marriage, noticed to have abdominal distension at the age of 1.5 years. Now he's had 2 episodes of seizures, generalized tonic-clonic convulsions in the past. The parents don't know what it is. They said they were given an IV infusion and in a hospital, and he got immediately better and woke up. No history, any other positive history really. The parents, when asked specifically, say that the child has a voracious appetite, often vomits in the night, and gets up in the night and demands milk. And every 2 hours, the child needs to be fed, otherwise becomes very irritable. His otherwise milestones seem okay. What do you think is the diagnosis?
Metabolic disorder, madam. Some causing hypoglycemia, hypoglycemic conversion recur with the IVs.
Yes, perfect. So this looks like a metabolic problem. There is hypoglycemia, related seizures. There's no jaundice though, and this is So this is a glycogen storage disorder. Somebody is talking of junk food. Yes, we'll talk about that in a minute. We'll come to junk food very quickly. So next slide, please. So this is the sonography of the child. The pediatrician finds the liver quite enlarged, and so he's actually, the distension is not really free fluid, but a large liver, and on sonography, it's a fatty liver. Now, please differentiate a fatty liver is it non-alcoholic fatty liver disease? No. A 1.5-year-old child coming with fatty liver, is a metabolic problem. So this is a metabolic problem. That's the first thing. Next slide, please. So these are the investigations. So most of the things are normal, except his enzymes are high. And there is some intervention which we do in June after seeing these enzymes when they start coming down a little. His LFTs otherwise are okay. Triglycerides are high. And we do random sugars which are not contributory, but we ask the parents to do a sugar level at home with a glucometer. We ask the parents to keep a glucometer at home and do the sugar when the child gets up in the morning. That's the important thing, because that is when the child is irritable and demanding food and turns out to be 50. Then we ask them to do sugars before he demands feed, and each of these sugars are in a similar range. So definitely documented hypoglycemia, but do it at the right time. First thing in the morning and before the demand of feeds. If you do randomly, immediately after feed, these are the sugars you will get. So this is an important finding. So low sugars, high enzymes, and next slide, please. So these are the differentials really. So this is a metabolic problem. This is not a non-alcoholic fatty liver disease, which we talk about a lot nowadays. So these are various differentials, but the commonest one, I'm not going to go into each of these, is glycogen storage disorder. So what is it? Next slide. So we do a liver biopsy. Liver biopsy shows these pale cells. You can see these are pale cells which nuclei pushed to one side. There's some fat in it. And we do a pass stain, pass with diastase, and that suggests it's a glycogen storage disorder. So if you have a child with progressive hepatomegaly, no splenomegaly, it can come later though, seizures suggesting hypoglycemia. So hepatomegaly may be incidentally picked up or maybe picked up by the way the child came to us with hypoglycemia, high enzymes, otherwise normal function. Think of a glycogen storage disorder. And this child was glycogen storage disorder type 3, where typically the enzymes are high. Usually in type 1, the enzymes are not so high. And this child was then put on a uncooked corn starch diet, which releases glucose very slowly, and after which his enzymes got normal. So this is a case of glycogen storage disorder. Think of it, large liver, low sugars, high enzymes. It's a GSD. Next slide. Okay, thanks. So this is coming to the next case. This is a 13-year-old. Now note the difference in age. BMI 30. Comes with dull right upper quadrant discomfort. He says, whenever I get up from the lying down position and sit up, I get this pain. When I get up from sitting to standing, I get this. It's not really pain, it's a discomfort. He has a 3 centimeter soft hepatomegaly. Look at his enzymes, mildly raised. GGT is mildly raised, everything mildly raised. Everything, CBC is normal, albumin normal, bilirubin normal. Now, there's a history in the family. Both mother, father, obese. This child is obese, mother diabetic, father dyslipidemic. So here the diagnosis is very obvious. Somebody has put MALD. Now, what is MALD? People, we talk of it as non-alcoholic fatty liver disease. There is a suggestion that it should be called metabolic dysfunction associated liver disease, though not everybody agrees yet, and we are sticking to NAFLD. There's a big debate going on. So we are sticking to NAFLD as of now. Now, this is the clue. He has acanthosis nigricans. Look at this for this pigmentation in the neck, axilla. This is where you'll find the pigmentation. If you have that, this is a child with metabolic syndrome. This is the age group. Yes, next slide, please. It's fatty liver on ultrasound. We do a fibro scan. So whenever you have a child like this, especially with high risk factors, a child who has family history or any associated comorbidities which suggest a metabolic syndrome, it's a good idea to do in addition to an ultrasound, do a fibro scan. Now the ultrasound is only showing a fatty liver. But the fibroscan is going to tell you whether there is fibrosis or not. Finally, what are we worried about? We are worried about inflammation and fibrosis. So this was a case of NASH, okay, non-alcoholic steatohepatitis. His enzymes are high. He is developing fibrosis. Anything, when we talk of fibrosis, next slide, please. It's a grade. It's F0, which means no fibrosis, to F4, which means extreme fibrosis or cirrhosis. So your fibroscan will tell you whether there is significant fibrosis. You may have a patient, and we saw a lot of these patients, mainly adults, who got their CT scans done in COVID, and their CT scans were done obviously for the COVID, but the CT of the chest showed that there was a cirrhotic liver, because they took uppercuts of the abdomen and they saw cirrhotic livers. These patients had normal LFTs. The ultrasound just showed a fatty liver. There was no cirrhosis mentioned, but the CT picked it up. But even better than CT is a fibroscan, which picks up early fibrosis, which tells us, and that's a way to, in a way, counsel the family, convince the family as to why they should get serious, because this is a major problem we are facing today. It is in adults become a problem which is the commonest cause of liver disease, and I'm sure in children also. There's a study of school children from Delhi, from Apollo Delhi, where they have found that it's almost 25 to 30% of school children who were overweight had a fatty liver. So it is going to be a problem, and it is already becoming a major problem. Now, a classic NAFLD is seen in a older age group. So if you have a 1.5-year-old, you're not thinking of NAFLD. You're thinking of a metabolic liver disease, the ones which I mentioned. But if it's a 8-year-old or a 10-year-old like this boy, think of a non-alcoholic fatty liver disease. And then there are various stages. You may have only a fatty liver, or you may have NASH, steatohepatitis, where there is inflammation and fibrosis. Then it develops into cirrhosis. And finally, it is a hepatocellular carcinoma. So 20% of those with NASH will develop cirrhosis. And hepatocellular carcinoma is actually now becoming the commonest etiology for a hepatocellular carcinoma, which we now see is a NAFLD. So it's a scary problem. And I think we really need to work hard on getting our children to exercise more, go off their mobiles, stop the junk food, everything. I mean, we can have a whole lecture on NASH, but it's an extremely important problem, just to highlight it. And to differentiate this fatty liver disease from the fatty liver disease of the 1.5-year-old, which I showed earlier. Any questions on this? If not, then we can proceed to the next one. Okay, so this is a 40-year-old male child. Parents noticed that there was diaper staining, and on examination, so they came to us saying that, is there a problem? On examination, the child is very active. He's got good weight gain, but there is a palpable liver. Now, I've mentioned bilirubin values in micromoles. So I gave this talk for somebody else. So basically, bilirubin is about 10 milligram, mainly direct. AST, LT are high. And look at this, alk-phos GGT significantly high. So when you have a liver profile abnormality, in your mind, you have to think, is this hepatitic or is this cholestatic? So here the enzymes are not that high, but your alk-phos GGT are more than 3 to 5 times normal. So this is a cholestatic illness. Albumin marginally low, INR a little high. So we've given vitamin K. Next slide, please. We asked the mother to get a sample of the diaper. We want to see the stool. The mother says it's a normal. It's the first child. Mother thinks the stool color is normal. We asked her to get a sample, and this is the color of the stool. So clearly this doesn't look normal. And there's a chart. I have not got the chart here. So we asked for a chart and we compare, and this clearly is fitting. There's a chart of various stool colors, which in many countries is distributed to new mothers. where they look at the stool color because they are not familiar what is normal and abnormal in their child. And if anything which is pale, they report and always insist on them getting the diapers and showing you the diapers or taking pictures of the diapers when they, whatever color they may feel is normal or abnormal. Now we do an ultrasound. That's the first thing you do when you have a cholestatic liver disease. Ultrasound shows a collapsed gallbladder. It's not very well seen, biliary not well visualized, just a enlarged liver. And then in today's day and age, we do not do HIDA. We straight go for a liver biopsy, which confirms it's a biliary atresia. So diaper staining and pale stools. This combination in a child who has basically, who is not sick, who's active, gaining weight, is a typical biliary atresia, commonest cause of neonatal cholestasis. Now, somebody is asked treatment of NASH. As I said, you know, we are really beyond treatment. It's mainly lifestyle and weight reduction. But I think we'll go on to this case because we can have NASH as a separate topic sometime if you wish. So next slide, please. So this is a classic case of biliary atresia, and the treatment is a Kasai. We should try and get the child operated within preferably 60 days, though even up to 3 months or even sometimes later, the children do get operated. We don't go for a first direct transplant. Those there are groups which are proposing that we should go for a direct transplant because there's a 30% chance that the child may not need a transplant. So we always try with a Kasai. The only time when we say no, go straight for a transplant is when the child has come with full-fledged portal hypertension, the spleen is enlarged, there is ascites, then that's a child where you're not going to subject them to Kasai, but go straight for a transplant. So talking of cholestasis, so this was a child with cholestasis. It means stagnation of bile or reduced bile formation or excretion. Now the important thing is that the bile is produced in the liver through the bile canaliculi. It comes into the main bile ducts, gets stored in the gallbladder, and then every time one eats, the gallbladder contracts because the bile is needed for absorption of fat and fat soluble vitamins and comes into the duodenum through the common bile duct. The important thing is when there is cholestasis, high alphos, high GGT, child is coming with itching, which is the main symptom of cholestasis. Of course, you can't appreciate cholestasis in a 40-day-old child. It's only after 6 months that you start appreciating itching, and typically they itch on their ears. That's the first place where they itch. You want to differentiate, is it intrahepatic cholestasis? Is it a drug? Is it TPN which the patient is being given? Is it some intrahepatic cholestatic disorder like a PSC? Or is it an extrahepatic? When you say intrahepatic, in the liver, extrahepatic is in the biliary tree. Based on the symptoms like itching, bilirubin, alphos, GGT, you cannot differentiate intra from extrahepatic cholestasis. You can have a viral hepatitis with very severe itching, and that is intrahepatic cholestasis. So you cannot differentiate the two. Next slide, please. So first test you do is when you suspect a cholestatic jaundice is an ultrasound abdomen. So can anybody tell me on, no, okay. What is it on a ultrasound which will tell us whether this is intrahepatic or extrahepatic straight away?
Gallbladder.
Gallbladder may not tell you. For biliary atresia, yes. If you don't see the gallbladder, yeah, that's the other important thing. In a biliary atresia, you should try and have the child fasting for at least 4 hours if it's possible. And then give the child, feed the child and see whether the gallbladder contracts. So if you see a good gallbladder distended, which contracts after a feed, then you've ruled out biliary atresia. So yeah, gallbladder is one thing for biliary atresia specifically.
Common bile duct diameter or this size or lumen?
Yeah, you're correct. The one thing to say is if you have a dilated biliary tree, if this is intrahepatic biliary radicals or common bile duct dilated, it straight away tells you this is extrahepatic.
Okay.
So ultrasound is a brilliant screening test to differentiate the two, because your differentials are totally different. Okay, next, we'll see it here. So is it a normal biliary tree? Next. Or is it a dilated biliary tree? Next. If it's a normal biliary tree, these are intrahepatic causes. So you can have conditions such as PFIC or bile acid synthetic defect. Now, in all cholestatic disorders, alk-phos is always high and GGT is also always high. But if they are normal, then you think of PFIC, progressive familial intrahepatic cholestasis, or a bile acid synthetic defect. Or you have other conditions like PSC. Many drugs like your Augmentin, amoxicillin, clavulanate can cause cholestatic hepatitis. Allergy is another condition. Dilated biliary tree, next. It can be various causes again. Biliary atresia, choledochal cyst, inspissated bile, or any other cause of biliary obstruction will cause a dilated biliary tree. So this is a very good algorithm and a good, but the important thing is a good ultrasound. We see many mistakes in ultrasound, so trust your, send your ultrasounds to that 1 or 2 or 3 sonologists whom you trust, because it's a very, very subjective test, and that's where sometimes we run into problems. Get it done by a person whom you trust and who gives enough time to do these ultrasounds. Next. So if there are any questions we can take on this case, otherwise we'll move on to the next case. Okay. So this is a 15-year-old boy who comes with fever of 1 month duration. There's nothing else to suggest the cause of fever. His basic tests, everything normal, including X-ray chest normal. Just the ESR is 45 and ultrasound shows hepatomegaly. What would you do next? Anybody? So it's like a fever of unknown origin. Nothing to suggest the likely cause. Just that there is a 45 ESR and a hepatomegaly.
Your function test.
Yes, okay. Yeah. Anything else?
You see for the causes other than liver, fever causes. It may not be, it just be one of the clinical sign of the other diseases or other diseases, which may be multisystemic disease.
Okay, but only thing we have got is a hepatomegaly. So yeah, you can get that also in a multisystemic problem. So yeah, nothing was very clear. So we did something next. So this was a liver profile. Alkaline phosphatase above 1000, AST, ALT and mildly raised, bilirubin normal. So now again, I want to ask, what would you do next?
It may be AST up to 120. Will be normal.
Does it look like amoebic liver abscess, this profile? I'll tell you the CBC is normal. In an amoebic abscess, you will expect a high white cell count.
Right.
And that is because of the liver amoebic abscess itself. Just because the white cell count is high, we don't give them antibiotics. So, but the white cell count here is normal. INR is normal if you want to know the INR. Anything else you would want? Your alkaline phosphatase is sky high. I'm giving you a clue. Somebody saying Wilson's. Wilson's is a hepatitic illness. So in Wilson's, your enzymes will be much higher. Yeah, usually they're less than 400, but it will be 100, higher. Get an alkaline phosphatase, which is 1200.
Maybe cardiac disease, like maybe it's causing some congestive hepatomegaly.
Again, in congestive hepatomegaly, your alkaline phosphatase will not be so high. What did I say? What is high alkaline phosphatase indicative of? Cholestatic liver illness. Don't say obstruction. Don't use the word obstruction, because when you say obstruction, you mean extrahepatic obstruction.
Okay.
But I told you that
And
extrahepatic and intrahepatic can be both very high. You cannot differentiate the two. So just say cholestasis. Okay. High alkaline phosphatase is cholestasis. Cholangitis is one cause of cholestasis. So, but there's no cholangitis here. Why? There's no fever. There is fever, but it's not fever with chills. Number one. Number two, the white cell count is normal. So this is not cholangitis. Now somebody has asked, Dr. Preeti has asked bone. Yeah, that's a good one. That's what I want to emphasize. When you have a isolated rise in alkaline phosphatase, don't only think of liver, think of bone. And many times you'll find there's vitamin D deficiency or something to do with the bone, which has caused a high alkaline phosphatase. But here there is a large liver. So is there anything else you would like to do now to differentiate whether this is bone or liver? I've spoken about that test earlier.
Bone and liver, CPK.
No,
Calcium
Bone.
phosphorus.
bone and liver. GGT. Yeah, who got that? Dr. Vikas. Okay. So basically, alkaline phosphatase and GGT go hand in hand, except those two exceptions. PFIC and bile acid synthetic defect. Forget about those. But here I want to know whether this high alkaline phosphatase, because I have no clue what is the cause of fever, whether it's coming from liver or bone. So the next test I would want to do is a GGT. If the GGT is high, this is liver. If the GGT is normal, this is bone. Okay, next slide, please. So what we do is, or what gets done is a CT scan, because it said hepatomegaly. So we think of a CT scan. And this is, I have purposely not shown you the GGT. And this is what the CT scan shows. Anybody? What is this? So these are micro abscesses, hypodense areas, like a cluster of hypodense areas seen in the liver, which is supposed to be, now we have learned it's a very classic finding of something. Diagnosis, this we biopsy. And we also send it for cultures. Okay, brucella is a good guess, but this is not brucella. Anything else? Somebody actually had given this answer earlier. That's a clue. But we did not talk about it. I purposely didn't talk about it. This is not hydatid. No. Hydatid typically will not come with fever as a presentation. Histiocytosis X is really exotic. I would think of something much more common. It's not amoebic. E. coli, why should think there's no GI symptoms? It's only hepatomegaly and fever. Pardon? Yeah, TB. It is TB. So this is a typical appearance of hepatic TB. And this was a patient who had isolated primary hepatic tuberculosis. And we did a biopsy, gene expert and AFB culture, and they were all positive for tuberculosis. So just to highlight, and then I'll show you the GGT. Next. The GGT is also high. So if you have a patient who has a high alkaline phosphatase, high GGT, and you do not find any evidence of cholestasis, the second differential is an infiltrative disorder. So both cholestatic and infiltrative disorders can cause high GGT. And that's what I want to highlight here. Next slide, which is the case here. So alkaline phosphatase, we said, comes from liver and bone. GGT to confirm liver disease, typically more than 3 times normal. Next slide. Isolated rise in alkaline phosphatase and GGT. Isolated rise, as I said, think of bone. If it is with GGT, then infiltrative liver disorder. There's so many infiltrative liver disorders where your histiocytosis and all these also will come in. Next slide, please. And malignancies. We have had patients of leukemia coming to us with just fever and high alphas, high GGT, marginally raised AST, ALT, and turned out to be leukemia. Of course, the CBC and the marrows have proven that. Now, this is just to show you a normogram of alkaline phosphatase. How it goes up, it's much higher compared to what you will see in adults. So this is females on the top panel, and this is males on the bottom panel. Now what you see is that the females have normalization, or I would say achieving adult levels of alkaline phosphatase faster than the males, and that is understandable. They grow faster, they achieve puberty faster. So this is at 14 to 15 years, they will start falling down and reach the adult levels, whereas the males, it's about 16 to 17 years. And this is the graph. You could take a picture of what the normogram mean alkaline phosphatase levels are in children. Next slide. Same for gamma glutamyl transferase. Now this enzyme earlier used to be called GGTP, transpeptidase. Now it's called GGT. As I said, it's a very important test, and most of our liver profiles which we do from outside do not include GGT. And I always tell in every talk, please urge your labs to include GGT in the LFT. It's a very important test, and especially in children where alkaline phosphatase is even normally higher than the adults. It's very useful when you have an isolated rise in alkaline phosphatase to tell you source liver or bone. Next slide. So this case, the biopsy, as I said, was suggestive, and the GGT helped us to tell us that this is coming from the liver. Next slide. So again, showing, yeah, next slide. So these are the values of GGT. As I told you in the first slide, GGT values are high in infancy also. And this is again a picture you could take of what the normogram in male females is a little different. So by about 7 to 12 months of age is when they achieve adult levels. So in infancy, it's very important to see the GGT because you're seeing patients of PFIC, you're seeing patients of biliary atresia. You want to know what the GGT is like because that will give you a clue to the cause of cholestatic liver disease. You just need to know that GGT in infancy is different from GGT in the older children. Next slide. This is the next case. This is an 11-year-old. He has developed acute hepatitis, possibly related to a drug. He's taken a salt of erythromycin, which can cause hepatitis. Anybody? Which one? Which salt of erythromycin can cause cholestatic hepatitis?
Erythromycin is stolate.
Yeah, not steroid. Yeah, so estolate. And so his drug is withdrawn, his bilirubin, his enzymes start coming down, if everything starts coming down. But even at 3 months post taking this drug, his bilirubin remains high. And again, I put this in micromoles. Basically, the bilirubin is 3 with a direct of 0.3. Rest of the LFT is normal. Denies any high colored urine. He says this is the urine sample we ask him to bring. So a normal urine sample and a high bilirubin. What is the differential? CBC is normal, hemoglobin 13.5. Ultrasound normal. Anybody? Diagnosis? No, this is not Wilson. Wilson's will have high enzymes. Yes, you're right. Sometimes Wilson's can have a jaundice which comes down. But what will remain abnormal is not bilirubin. Bilirubin also may remain abnormal, but the enzymes will remain a little abnormal. They'll not come back to normal. Yeah, so Praveen has said Gilbert syndrome, and this was indeed Gilbert syndrome. So what is Gilbert's? Important word here is isolated. So whenever you have an isolated hyperbilirubinemia, you think of a genetic cause. So these are patients who come who are doing liver function tests for whatever reason because they are found to be jaundiced by somebody. Somebody notices that their eyes are yellow. They typically don't have any prodrome or anything. Their eyes are yellow. And sometimes you pick them up after an attack of acute viral hepatitis because they are being followed up with LFTs and we find that the bilirubin is not coming down. Sometimes we pick them up after starvation, during Navratri or Ramadan, we find that they have bilirubins which are going up and their eyes are shown to be yellow because we have seen it after starvation. Next slide. So it's quite common. So if you have a LFT, which you are saying, where only the bilirubin is high, think of Gilbert's. It's seen in 5% of the population. At the baseline, it's rarely more than 5 milligram. It's deficient uptake by the liver, but it is acholuric jaundice. Acholuric means it's not, the bilirubin is not being excreted by the kidneys. So your urine color will be normal. So this is the easiest test to see whether the child has direct or indirect hyperbilirubinemia. Yellow eyes and normal urine, this is indirect or acholuric jaundice, indirect hyperbilirubinemia. Your differentials become totally different. You don't want to do viral markers here. You don't want to do autoimmune markers here. You just want to test the urine and confirm. Urine, absent bile pigments. This is indirect hyperbilirubinemia. What are the common causes? One is hemolysis. What is the hemoglobin? What is the retic count? What is the peripheral smear? Is there any evidence of hemolysis? No. Then it is by default Gilbert's. What is the other cause of indirect hyperbilirubinemia with all other liver function tests normal? It is Crigler-Najjar. Yes, it is Crigler-Najjar type 1 or 2?
2.
2. So what is type 1? Which is the enzyme which is deficient in Crigler-Najjar?
Transferase enzyme that.
Yeah, you're right. Glucuronil transferase. It's an enzyme in the liver which converts indirect to direct bilirubin, or rather unconjugated to conjugated bilirubin. So when this enzyme is deficient, you get Crigler-Najjar. If it's totally deficient, it's type 1. If it's partially deficient, it's type 2. Type 2 is compatible with life. You give enzyme inducers, like which drug? The bilirubin will come down. Phenobarbital. So phenobarbital induces this enzyme and your bilirubin comes down. Typically in Crigler-Najjar type 2, it's indirect hyperbilirubinemia, but it's between 5 and 20 milligrams of bilirubin. Unlike Gilbert's, where it's less than 5, unless the child is starving or going through a stress where the bilirubin can remain high. And this is the most important thing you need to tell the family. Stop doing LFTs again and again, and they get hyper, they keep on doing tests, and they really become, and the child is put on all kinds of diets because there is jaundice. Child is losing weight because of the diet, not because of the jaundice. So the most important treatment here is to reassure the family. It's reassurance that this is a genetic disorder. You may do this mutation. Many labs do it to prove it is Gilbert's, but I mean, typically you can be pretty sure even clinically and on your biochemistry. You have to just reassure the family that this is Gilbert's. The child can have eyes becoming very yellow if there is a stress, like after a surgery or prolonged starvation, and you just need to wait. It's not going to cause any damage to the liver. On the other hand, if you have isolated direct hyperbilirubinemia, this was indirect, much more common. Direct, much less common. Here also Dubin-Johnson is the common one. So isolated hyperbilirubinemia, indirect, either hemolysis or Gilbert's or Crigler-Najjar type 2. Direct, Dubin-Johnson or Rotor. Dubin-Johnson more common than Rotor, but both much less common than Gilbert's. So think of a genetic problem when you get isolated hyperbilirubinemia. Next slide. Yeah, next slide. Next slide, please. Yeah, so I will go through the classification of liver disorders. So if I have to sum up, I don't know if there's a case in this one, but if there is, I'll go through that case. But if you have to sum up the liver profile or the presentation of the patient, you either define it as a cholestatic, where the child mainly comes with itching and clay stools, unless it's a very young child. Typically, they have high alk phos and GGT. Hepatitic, where they come with high AST, ALT, the differentials are totally different. We're talking of PSC, we're talking of biliary atresia, we're talking of certain drugs, choledochal cysts who come with cholestatic. Hepatitic, it could be viral, it could be NAFLD, it could be Wilson's, it could be autoimmune. They often have, it could be drug prodromal symptoms. So high AST, ALT. So the reason to classify into these various categories is that your differentials become narrow and you do tests only required for that. You don't need to do the whole battery for all the patients. Patient coming with liver failure, how do you define? INR prothrombin time, which does not get corrected with vitamin K and is high, and they may progress to altered sensorium. Child coming with predominantly organomegaly could be a storage disorder. If it's mainly hepatomegaly, it's a glycogen storage disorder. If it's a splenohematomegaly, the common one is Gaucher disease. And I've not really spoken about Gaucher, but there is treatment available for Gaucher, something which we can again talk in some other forum. If it's hyperbilirubinemia alone, as we just said, think of a congenital cause, especially if you've ruled out hemolysis in an indirect hyperbilirubin. So if you classify your patients into these headings, and these are the headings I covered under various cases, you can come down to the differentials of those cases. Next slide, please. Yeah, I think next, is there anything else? Yeah, I think that's the end. Okay, so if there are any questions, happy to take the questions. Yeah. Thank you, Dr. Hemant, for projecting the slides.
Thank you, madam. It was really wonderful and lot of pearls. Covered almost many diseases.
Actually, as the case going on, next case. So I think probably we need to again see the whole presentation on YouTube, because there are so many things actually to learn from every case. So there are small points you keep in mind. I need to read it again. Thanks, Agwa Nagar madam, for this wonderful topics and with the wonderful cases. We have learned a lot of things new, though it's not like that we are not knowing, but how to keep your mind specific on the specific reports, and asking the history of how many days itself makes a lot of difference. Like particularly the case which you shown us about the taking paracetamol. So it comes with paracetamol, something paracetamol poisoning and these ones, and it's actually something different. So there are so many things to learn and read very specifically what you are sending and when you are sending those topics. Hemant sir.
There are many questions being asked, but I don't know if individual cases I can say, but the broad ones I can say, yeah, LIV52, no role. No role for any liver tonics. If you ask me if there are any liver tonics which are known to improve the prognosis of a patient, no. So the thing is that, I mean, this is something I want to emphasize, that when you have a viral hepatitis, which is the commonest cause of jaundice, which we see, whatever you use is going to work. Why? Because it's a self-limiting illness. So whether you give LIV52, whether you give whatever, put a mal around the neck, or whatever boiled food you give, it is working. Why? Because in 99%, it's a self-limiting illness. But we are worried about that less than 1% who develop acute liver failure where nothing works. When nothing is going to prevent the liver failure from developing. So that 1% is what we are worried about. And what is the most important test there? It's a prothrombin time, which if you start seeing a child with rising bilirubin, please do a prothrombin time. Not getting corrected by vitamin K, please refer the patient to a transplant center, because this is a child who's in trouble. So that's what I would say, that really no drug, no allopathic or Ayurvedic or any other complementary or alternative medicine drug has been shown to change the prognosis of a patient of viral hepatitis if he is to develop a liver failure. Yes, we do use N-acetylcysteine, definite role for paracetamol, but For other non-paracetamol causes, it is still a question mark, but we still use it because it's a benign drug and we have nothing else to really give to these children. But otherwise, no role for Lola in acute hepatitis. Only role for Lola is in hepatic encephalopathy. There is no role for Lola in any acute hepatitis, or for that matter, even acute liver failure. No role for Lola. N-acetylcysteine, yeah. So I've mentioned that. Yeah, again, Samir has asked about Lola. No. Now, somebody is asking about gum hyperplasia. I don't know whether they are two related. Many drugs are associated with gum hyperplasia. Like, for example, I know cyclosporin is associated with gum hyperplasia, but I don't know. You can, if there's no transaminitis in your child, 12-month-old, please check the urine for bile salt, bile pigments. If there are no bile pigments, this is indirect hyperbilirubinemia. Then you work up accordingly. If there are bile pigments, it's a direct workup accordingly. Udiliv, no role. No role. Udiliv has very specific role. It's only for the cholestatic liver disorders we use UDCA. So don't use it for all the hepatitis patients. If there's cholestasis, there's itching, PFAC, other cholestatic disorders, we can use Udiliv, Utcament, or all UDCA basically, ursodeoxycholic acid. Vitamin E, yes, vitamin E has some role in NASH, but it gets the enzymes to normal. It does not reduce the risk of fibrosis. It does not reverse fibrosis. So that's an important point. You may get enzymes which are raised coming back to normal, but the fibrosis does not reverse with vitamin E. Urine normal, direct bilirubin increase. Now, again here, when you have a bilirubin which is not greatly raised, bilirubin of 2, 2.5, total bilirubin, the lab is not very reliable in differentiating direct from indirect. And you may get a bilirubin of 2.5, your direct is showing as 1, okay, or 0.7. So it is more than 15%. When you define direct hyperbilirubinemia, more than 15% of total, it's direct hyperbilirubinemia. So by your calculation, this is direct, but your urine comes normal. That is because when it comes to lower levels of bilirubin, the labs are not accurate in differentiating direct and indirect. And this is a very, very common problem we face. So the easiest thing to do is do the urine test. If the bile pigments are negative, assume it is indirect and treat it and approach it as an indirect. G6PD deficiency, yes, G6PD usually will present with hemolysis, but it doesn't present with hemolysis just like that. There has to be a precipitating event. Often people get vitamin K. Vitamin K by itself can precipitate hemolysis in a G6PD deficiency. Usually there's a drug which is given which precipitates hemolysis. Total bilirubin 6 and direct was 5.4. Then I think recheck your urine from another lab. It has to show direct. It has to show bile pigments. Yeah. Okay. So I think I've answered most of the questions.
So, Samir, should we end this session with vote of thanks?
Yes, Jay.
Jay, Bandarakar sir, can I have one comment, if you
Yes,
permit?
sure, sure.
Yeah, this is Dr. Minhaj from Lilavati Hospital. One of the finest presentation that I have ever attended. A lot of compliments to you. The last slide was the sum up of everything.
Yeah.
One thing which I want to learn from you is use, misuse, and abuse of FFP in hepatic disorder.
Yeah, I think it's a very, very relevant point. I did allude to it, but yes, since you're asking, I think it's a good idea to talk about it. Basically, it's abused very often. And abused, I say, because FFP is not a small volume. The volume of FFP is large. Do not give FFP. Where are you likely to think of giving FFP? Where the INR is high. And you start thinking, oh, INR is high, let me give FFP. First, INR is high, give vitamin K. No response to vitamin K, you know now this is a liver problem. This is not a cholestatic problem. Your liver is sick. So it's a concern. Now, do you give FFP? This is a child with acute liver failure, INR 6. Do you give FFP? No. I'm putting in a central line, I'll give an FFP. Child is bleeding from the nose, I'll give FFP. no bleeding, no invasive procedure, do not give FFP.
Perfect.
Child going to transplant, I've decided this child needs a transplant, I'll give FFP. So only if the child is undergoing an invasive procedure or, you know, bleeding from some site, you give FFP, otherwise not. You may argue why not give, you know, it's more a placebo thing for you than, and maybe the parents, than the helping the child. Problems, we know TRALI, transfusion associated, you know, liver injury, lung injury, or
TACO.
even overload. We see so
Even
much.
TACO.
Yeah, exactly. So we should avoid FFP as much as possible unless it's really indicated.
Thank you. Thank you, madam.
Most welcome.
So thank you as the icing on the cake of the last episode of our sub specialty this year. Thank you from bottom of heart to Abha madam taking, I know you are so much busy, but out of 30,000, 35,000 pay addition all over India are waiting for the pulse of various subjects. And it was a fantastic, I can say, I took a lot of pulse. Rather, I can make a necklace, बांगड्या म्हणा किंवा काही मुकुट काही पण करू शकतो एवढे मला पल्स मिळाले. तर मराठीत बोलेन की दिस द बेस्ट ट्रीट आय एव्हर गॉट this year. This pulse from you. So thank you very much. From our MAHAP team. I will get back to you again next year also, so that we can recollect the things. We will contact you. So thank you very much, madam, and thanks to Dr. Neha, Dr. Vishal, our MAHAP president, Dr. Hemant, Secretary Amol, and all office bearers, and as well as my I've been the co-moderator of Dr. Samir. And we enjoyed this get-together of this subspecialty. All these almost 500 academic sessions are available on the MAHAP YouTube. And I know many of us, persistent number was there, and many of will go back to that same even today's presentation and collect and recreate the pulse again and again, and so that they can imbibe in our practice and give a better treatment. And most important thing, refer in early conditions so that our patient may get like a Kasai operation, not needed any liver transplant, as well as our own, maybe many idiopathic liver failures are there, so that they can correct treatment earlier and they can survive, because we have fantastic, I think, prognosis in many liver transplantation. So thank you very much. Over to Samir to conclude. Any remarks from the Dr. Hemant?
Dr. Hemant sir, actually I forgot to mention him in the early phase. I realized later. So sorry for that. Hemant sir, please tell a few things about this today's topic and about the MAHAP Sub Speciality channel.
No issue, Samir. You both have done wonderful job throughout the year, and this was the 11th episode of the Sub Specialty Connect, and we got all these sub specialty sessions in this format. And really, you have both of you, Dr. Jay as a state convener, Dr. Samir as a EB member of the MAHAP, worked beautifully to give all these pearls throughout the year. And I remember, we remember distinctly the episode where Dr. Ravi sir were there with access. That touched the benchmark of almost so many thousands attending on that. And so, as already Dr. J has said, we have these all videos all on our MAHAP YouTube channel. One can revisit again and again. All these are on MAHAP YouTube channel. So I think so. It was a wonderful 11. We planned to do only 9 episodes, but then these two people went on ahead to do 2 more episodes. So we were very lucky to have an extraordinary and excellent faculty, Dr. Abha madam, talking on liver. And I remember because I am also from KEM, so I know about her. Lot of work she used to do at the KEM. So these things, and it was wonderful.
Thank you.
So we also, many of them have joined this session, and thank you, Dr. J, Dr. Samir, for this wonderful journey in this year. And probably this is the last episode of Maha Sub Speciality Connect, and probably we may see another episodes in next year. Let's hope for that. With that, Dr. Samir, would you like to say something and then conclude?
I will conclude the session for today's done by Dr. Abha Nagral madam. And not to forget about the few more people, specifically I will tell one is of this is Dr. Vishal Raut, who has made fantastic flyers, because a lot of people ask me how you made these, what as the person is behind this person. He always remain behind the screen. But all these topics, if you see that made in the blue, or like we say the men in blue is like an Indian cricket team. So man in blue behind this particular, all the topics, if you get the, you see the, all the flyers, you will have similar type of thinking and something very specific. As soon as you see the logo, you'll realize, oh, something is there. This is Maha Sub Speciality. Similar way, if you see on the channels or YouTube versus also on the Zoom, or like what you say, writings of particular only 2 lines. Dr. Neha Singh, are you there? I hope you are there. So she made a lot of thinking on that particular, what to write specific words. And I'm so happy with her that in last 10 or 11 episodes so far, she has come up with very fantastic specific few words and then come up with the ideas. Dr. Chitra Madam is also there. She's handling all the online sessions and the Zoom as well as on the YouTube. And also, obviously, we have to thank Hemant Gangulia sir. He is giving us the support and all the help, whatever is needed. And so is the Amol Pawar sir from the secretary part. So thanks, Jay Vandrakar sir. It was very nice. So far, we have done our journey. Next year, we don't know whether we are going to continue this session. And if you are going to continue this session, might be a good idea that we start with asking for like a 2 or 3 hours of CMEs. So we'll also have some credit points or like MMC points for that. Because a lot of people actually ask me, is there any particularly that we can get some MMC points? I say for 1 hour session or 1.5 hour sessions, generally MMC points are not granted unless we have like a suppose 3 or 4 sessions. So like particularly if you see maybe on Friday or like on Saturday, Sunday, generally Saturday, Sunday, everybody is busy with some or other work. So we have to check out something called 6 to 9 p.m. or 9 to 12 p.m. or like a mini CME for 3 to 4 hours with a multiple specialists coming together. So let's hope for that. And thanks for everyone here. Thanks, Minaj sir, you are here and for asking valuable questions. There are many people, I can't tell each and every person's name, but thank you for participating till last. And we will conclude these sessions for here. So we can stop now YouTube live.